try wide conduction system pacing. Anatomy and physiology of the conduction system quickly. His bundle versus lead bundle area pacing. Step-by-step approach of lead bundle area pacing, which I'm not going to spend too much time. Definition and characteristic of lead bundle pacing. And then lead bundle branch area pacing for cardiac resynchronization therapy and current guideline. So why conduction system pacing? I will take you back to this giant in the field of cardiac physiology, Dr. Wiggers. That time he showed, look at this, LV pacing, baseline LV and the aortic pressure. You pace the LV, and then aortic pressure goes down. The same thing, again, native versus LV base. When you pace the LV apex or LV base, the pacing, the aortic pressure goes down. That's such a brilliant, you know, this slide is from 1925. It's a brilliant slide though, brilliant thought, you know. Look at this. This was work in Mass General Hospital. In the left part of the slide, you see there is AV dissociation because of the pacing. Look at the arterial pressure. The right part of slides, A and V, they are associated. Okay, AV association are there. Look at the pressure in the aorta. The arterial pressure goes up. So AV dysynchrony plus ventricular pacing alone, that makes difference. This is a very old slide. Probably I was just finishing my fellowship. Most trial came, but old is okay. Old is fine, you know. And that slide quickly showed that. With the dual chamber as opposed to single chamber pacing, there was not much difference in the stroke and death rate. But look at the basic. Look at the basis though. The hospitalizations for the heart failure improved, and the atrial fibrillation improved with the dual chamber pacing as opposed to single chamber pacing though. That was the most tried. So recently, all these company people, they have come with different features to try to minimize the ventricular pacing. Okay, I will just quickly. Managed ventricular pacing, which we call MVP mode with the Medtronic. Ella came with a different one. Ventricular intrinsic preference, St. Jude came, okay, depending on the rate, how the change in the AV interval goes. All these are to decrease the undue ventricular pacing, okay. But you are sacrificing one thing. You are sacrificing the AV delay. Sacrificing the AV delay. And sometimes too long AV delay can lead to pacemaker syndrome, and a long AV delay has been shown to be cause of arrhythmia as well. So arrhythmogenic cause. So none of these suffice the 100% requirement that you should not pace the RV. Okay. So I think this slide has been shown by Dr. Samuga that when you do the HIS pacing, death, heart failure hospitalizations, or chance to upgrade to biventricular pacing is much lower with the HIS pacing as compared to the regular pacing. Right ventricular pacing, the red, the blue line is the HIS bundle pacing stuff. So HIS bundle versus lead bundle area pacing. Okay, I always tell my fellow that, okay, when we started HIS pacing, it used to be a nightmare. I didn't used to like it. I used to be tense. I'll get it or not get it, okay. So I used to say that, okay, if you are landing the helicopter on the small helipad versus landing the helicopter on a big helipad. So what happens? Look at the anatomy. I just put the marker there. That when the left bundle, his area is small It is encased in the fibrous tissue. Sometimes it's hard to paste the His though. But when it converts into lead bundle, it fans out. It fans out, you have a bigger area to choose. So that makes it a lot easier to paste the lead bundle. This was a brilliant presentation, a brilliant study by Roderick Tung group from University of Chicago. Look at this. They were doing the EP study. What? Anyway, the pointer isn't called. So what they did, they found that there were some PVCs which you can call, lead bundle branch block pattern. V1 is not completely QS complex. And then there are some PVCs which are very wide. The third PVC, third complex is very wide. I put the second one. And at the same time, what they put this catheter on the His, and they put the catheter on the left side of the septum. Okay? Watch here. When you have the native complex, you have A, His, and V, and then you are, put that catheter on the left side of the septum, you have H, lead bundle potential, lead bundle potential, lead bundle potentials. Look at the second complex, which looks like lead bundle branch block, but you can call it, okay, left intraventricular conduction delay. Look at this. Still it has H, lead bundle potential, lead bundle potential, lead bundle. It looks like a normal. Okay. But when the PVC is very wide, okay, on that one, so what happened here? There is A, H, but there is no left bundle potential. So it was not left bundle branch block. Most of the left bundle branch block, we look at this EKG and this, okay, the block is in the His, it's intrahesian. Okay, the block is intrahesian. So complete conduction block, but look at the block is between the His and the left bundle potential, not in the left bundle branch itself. So this was the great thought. So look at this. You have a AV node, you have a His, small area, and then divides into left bundle and the right bundle. So most of the left bundle branch block, the block is in the intrahesian area. So 18% of that, so left intrahesian block is 46%, 18% will be in the left bundle branch proper, and most of them have intact Purkinje activation system though. So this is a brilliant slide though. Okay, so depending on that slide, I would say the left bundle branch block is more often a disease of the conduction into the left bundle rather than within the left bundle branch block. This concept came, and that led to, emergence of the left bundle branch area pacing. Okay. So, resurgence of conduction system pacing for patients with symptomatic bradycardia and heart failure. So, why left bundle area pacing? That's why. His bundle pacing is an accepted alternative to more traditional RV pacing sites, RV apex or outflow tract. Or His bundle pacing is theoretically the ideal physiological pacing site. But there are some inherent limitations of His bundle pacings. Implant technique requires greater expertise in targeting a small zone, challenging in patients with dilated hearts. Long procedural and fluoroscopic times, spelling is wrong. There should not be E after FL. Fluoroscopic times. A reported success rate of 55 to 95%. So if I am doing in the beginning, it will take me half an hour, 40 minutes times extra than the 40 minutes time for the regular pacemaker implantations. And come on, if you are spending half an hour, 40 minutes times extra, and you have a success rate of only 55%, no way. Forget about it, okay? That kind of things. So typically, the R wave amplitude with the His pacing is low. It has a chance of oversensing the atrial or the His signals and undersensing of the V signals. High His bundle pacing capture thresholds at implant as well as follow-up, leading to premature battery depletion and repeated generator replacements. Unpredictable delayed rise in his bundle pacing capture threshold, leading to high lead revision rates. And there is no robust data regarding long-term performance of his bundle pacing available as yet. So question of an optimal pacing cycle led to novel cardiac conduction system pacing technique described first by Huang et al. In 2017, and the pacing lead was implanted deep into the right ventricular basal septum to capture the left bundle area in patients with heart failure and left bundle branch block. And this was basically a case report from Huang. So that the abstract says that it demonstrated the feasibility of pacing the left bundle branch immediately beyond the conduction block to functionally restore the impaired his Purkinje conduction system in a patient with heart failure and left bundle branch block. The pacing required only a low pacing output, 0.5 volt at 0.5 milliseconds, to correct the left bundle branch block with accompanying right bundle branch block on the electrocardiogram. And over 1 year of follow-up, the patient had a significant improvement in clinical outcome and echocardiographic measurements. The case showed a novel pacing strategy for patients with bundle branch block that affects many patients with heart failure. That was the abstract from this case, that case report. So left bundle branch area pacing, it is rapidly emerging as an alternative for failed cases or as primary strategy for conduction system pacing. It has a wide target area for left bundle branch area, and its histology. His bundle is encased in fibrous tissue, electrically non-conducting tissue around, versus left bundle branch embedded in the myocardium that favors left bundle branch area pacing over his bundle pacing for physiologic pacing. Okay, so quickly I'm going to go over the left bundle branch pacing technique. I won't spend too much time. This was from Dr. Vijay Raman, and I know the slide is not very big, but basically it has two parts. One is how you fix the lead. Okay, that is some practice. Is much easier than the his pacing. Then the most important part is, are you capturing the conduction system or not? So access the ventricular septal thickness by echocardiogram or SCAR. We don't do it routinely though. Okay, and then the initial site at the right surface of the ventricular septum. So what we do, I go RAO. I usually use the glide Y, which is very quickly go to the right ventricular outflow, and then over that we put the sheath, which is I'm going to show you, and then we give counterclockwise turn to make this septum, to make the sheath more posterior. Okay, and I confirm. To start with the RAO, I confirm the position of my sheath in the LAO. Okay, make sure it is facing posteriorly. Okay, and then once you do that, when we touch the right side of the septum with the lead, okay, you look for the electrocardiogram in V1. It gives you W pattern with a notch very proximally. So notch very proximally. And then you start rotating the lead. And as you do that, the notch will go more distal, and then eventually you get the QR complex. Okay, so that's the typical practical way. So once you are there, you confirm the left bundle pacing. Any one of them will do. You don't have to have all the criteria in every case. You will not find it. You will not get that all the criteria. So paced morphology of right bundle branch block pattern. Identification of left bundle branch potential, not easy, especially you have complete left bundle branch block, you may not be able to see the left bundle potential though. Okay, pacing stimulus to left ventricular activation time choose the lead V5, V6, measure the distance from the pacing spike to the first spike of the QRS complex, and if you are less than 75 milliseconds, then you should wash and go home. Okay, you're doing fine. So, and then determination of selective and non-selective left bundle branch area pacing. You start with a high output. I always use the electrogram. So we connect to the PUCA systems. We see the local focal electrogram also. And as you are the higher output, you are capturing both his as well as the myocardium. As you cut down the output, at one point the ventricular electrogram changes. I'm going to show you. So that means you are changing from non-selective to the selective one. Okay, one point is important to mention here though. When you are pacing the hiss, when you are capturing the hiss only, used to call it selective hiss pacing. QRS will be narrow. Okay. When you are capturing the myocardium also with the hiss pacing, QRS will be wider. In this case, it's reverse. When you have the high output, you are capturing both the left bundle branch area pacing as well as the myocardium, the high output. Your QRS is narrower. Your left ventricular activation time is narrower. When you lose the ventricular, the local myocardium capture, you are capturing the hiss only, then your QRS will be wider than the non-selective one. That's the difference. Okay, so then evidence of direct left bundle branch capture if you have. So these are the 3830 pacing lead. It is a lumenless lead. Okay, not very friendly, I would say, okay, as compared to our with the lumen lead. So 3830 lead, and this is the sheath C315 has fixed curve versus deflectable sheath. The fixed curve I'm more used to, but recently started deflectable sheath so that I can choose different areas without moving too much. And then this is how it goes. You have crossed the tricuspid valve, you are in the septal area, and then okay, so initially you will see this W pattern on V1 with a notch in the very early part of the QRS complex, and then as you are screwing the lead, okay, as you are screwing the lead 4-5 turns, few turns, and then screw the proximal part of the lead clockwise, you may see some PVCs. Okay, when you are irritating the right side of the interventricular septum, the PVC morphology will be of left bundle branch block pattern, and when you change it to the right bundle branch block pattern, that means you are in the right place. Okay, so as you are screwing, you see this notch gets distal, and at one point it changes to this pattern, okay, RS pattern, or you will have a QR pattern. Okay. If you see the left bundle potential, stop there. Okay, so that will not happen if it is a complete left bundle branch block pattern. But if you are right bundle branch block pattern, or patient has a left bundle intraventricular conduction delay, you may see the left ventricular LVB potential here, though. There's a very short interval at 24 milliseconds. And here it shows the change in the morphology of the PVC. Look at V1. The change was complete QS complex in the beginning. When you're on the right side, and as you go, it changes to that template beat I showed. That's the right bundle branch block pattern, though. Here it shows that you have non-selective. Look at the electrogram here, left bundle electrogram. Okay, it's completely fused, and your ventricular activation time is 72 milliseconds. QRS duration is 118 milliseconds, and you are pacing at 5 volt at 0.5 milliseconds though. When you cut down the output to 0.8 volt at 0.5 milliseconds, your impedance is in that area, in that zone, and then your left ventricular activation time will prolong, okay, and the QRS will be prolonged as opposed to this one, where QRS, you are pacing at the high output. Okay, so how do you know confirm the depth? We don't do it routinely, but just to show that your LV tip, sorry, left bundle branch lead tip is there, and then it shows, and then your die is on the right side. That distance, that will also confirm that. You can do the echocardiogram. If you have echo, well, we have portable echo in the lab. You can quickly see this. We don't do it routinely, but initially when we started doing it, we used to see it more often and make sure that that it is not crossing the septum here though. Then you can use the dual method, which I hardly use that now, where we have put one catheter, one lead on the His, okay, and then you can put another one on the RB septum and try same thing, and then the same lead which I have used for the His bundle, don't waste it, put that on the right atrium. Okay, so this is how it looks, and finally we move the His lead to the right atrial appendage. The same process is same basically. Here you may see there is a His here, left bundle potentials, okay, SV interval 40 milliseconds, left bundle to the beginning of the QRS was 20 milliseconds. But that doesn't happen all the time though. Plus I don't use that His sheath, his lead anymore. So same thing, that W pattern in V1 will change to the QR pattern, and this is, it tells you W pattern, and then the notch moves distally, and finally you have a QR pattern there though. Well, we don't spend time here. This is a long video, I don't want to. Let's see. Look at this, the bottom channel. We're pacing at the high output, and gradually we are going down with the output, and the local electrogram changes as you are capturing His only. There will be a change in the morphology on the local electrogram. So here you are still non-selective, too long. Okay, it's still non-selective, and then selective now. You got the local electrogram, again non-selective, and finally it becomes all selective, and finally you lose the capture. So this is from the non-selective to the selective mode.
Yes, sir.
So what are the complications of left bundle area pacing? You may have right bundle branch injury during the procedure. When you do the counterclockwise rotation of the sheath and fixing the lead at the inferior septum may decrease the chance of right bundle injury. Okay, so right bundle is mostly anterior part of the septum, so goes posterior the counterclockwise. If you have assistant there, ask him to hold the sheath in the counterclockwise positions though. The lead dislodgement and septal perforations, monitoring the paced QRS morphology and impedance. As Dr. Sunil showed that if you have sudden drop in the impedance less than 450, think about that you are in the left bundle, you have perforated. Okay. During each step may help to prevent the case. Adequate slack should prevent lead dislodgement. Potential for coronary artery injury, especially septal perforated branches, preferable that the lead be placed inferiorly and posteriorly, since large septal branches are in the anterior septum. So there are different leads by different companies nowadays. These are lumen leads, screw-in leads like a regular one. Boston has one, Biotronic came up, and the Abbott has one also. Anyway, this was one of my patients. I could not cannulate the coronary sinus. Finally, we put the lead on the left ventral branch area, and this was the baseline morphology, and this was when you pace the by IV pacing with the left ventral branch area pacing, though. That V1 was narrow and the QR complex. There are different presentations, different studies. They have shown that left ventral branch area pacing for cardiac resynchronization therapy as results from international left ventral branch area pacing collaborative study. The second one, third one, but basically all of them showed that the QRS durations has come down very clearly. New York Heart Association improves, the left ventricular ejection fraction improves, and the left ventricular end diastolic volume goes down. So this is basically the same thing. This slide I like. AV optimizations, when you do the AV delay optimizations, then you increase the stroke volume, you increase the systolic blood pressures. When you have a ventricular resynchronizations, you improve them further. But there is a point there is still the potential improvement for the additional improvement with left ventral branch area pacing.
Dr. Jha, can we conclude soon?
Yes. So in this, this is the current guideline of whenever you have a chance of greater than 40% pacing in the RV, we go for the left ventral branch pacing. So anyway, this is my last slide. Left ventral branch pacing wins, is easy to learn and execute. A stable lead performance workflow allows easy replacement of typical RV apical pacing in CRT, building evidence on the power of left ventral branch area pacing in lieu of right ventricular apex or even traditional CSLB pacing. And then, it is easy. You cannot call it successful if only a few can replicate it over the long term. Many of us can do that, okay? So that's why it's easy to do that. Finally, to conclude, left ventral pacing is a novel pacing modality that can bypass the pathological or disease vulnerable region in the conduction system to provide physiological pacing modality of the patients. Left ventral pacing guarantees a narrow QRS complex and fast left ventricular activation time with a low pacing capture threshold. And studies have shown that left ventral pacing can be applied to circumvent the limitations of his ventral pacing or RV pacing and can act as potential alternative to CRT in patients with typical left ventral branch block. And with that, I stop. Thank you.
Sir, one question, sir. Can left ventral branch pacing be made a routine, sir?
Sorry.
Can left ventral branch pacing can be made as a routine, sir, for all the patients?
Well, I was talking to Sunil that in my place, if there is a AV nodal conduction or whenever I feel there is a chance of more than 40% right ventricular pacing, I prefer to try the left ventral branch pacing though. You don't have to, but there is no data that, okay, this is the LVEF, below that you should do that, that. But because these are the patients, they have high chance of pacing induced cardiomyopathy, we prefer to do the left ventral pacing.